Today we're going to talk about constipation, which it seems like very basic and kind of a topic that most of you guys already know how to treat and see patients every day with it. Um, but it is the majority of the referrals that I get. So the goal here is to try to give a little bit of couple tools to keep the patients as an outpatient, and maybe we don't need to see all those constipation kids, although we're happy to consult if needed as well. Again, I have no financial relationships to disclose. And our objectives today are going to define constipation, kind of understand the pathophysiology and the cause of constipation, focusing primarily on functional constipation as well. How do we evaluate and manage those patients? And understand the principles behind, the functional constipation, which is 95% of the constipation that we see. And how do we discuss treatment and options with patients and parents as well? And how do we continue after that first visit they diagnosticated with functional constipation? Again, why constipation? It is very common. It's about 3% of all the pediatric visits. It's estimated that kids who are less than 3 years old, the prevalence of constipation varies from anywhere from 0.3 to 28% in people. Less than 3 years old is about 8%, and kids above 3 years old is around 11 to 14%, depending on what studies you look at it. So it may actually be more of the 3% of the pediatric visits as well. It could account for almost 25% of what we see in clinic. And the cost per year is high, not only with medications, but also with costs of clinical visits and different testing and over-the-counter medications and supplements as well. So for parents, it costs 3 times more for them to have a patient with constipation than not have a kid with constipation. And the healthcare costs, the last study that I could look at it was from September of 2008, was around 3.9 billion per year. If I adjust this for inflation for May of 2025, we're talking about 5.79 billion per year as well. And it's a big source of anxiety for parents. So for parents and for the patients as well. So, you have those kids having accidents, they're going to school, and some kids are making comments. So it can cause depression, anxiety. Some kids are avoiding social situations, and it may also be kind of a negative kind of reinforcement, and some kids may be punished because they're having those accidents and they're having constipation as well. What does the word constipation come from? It comes from the Latin constipare, which is actually to crown together. So you can see the imaging here, little hard stools stuck on the rectum area primarily. And it's actually defined, constipation as infrequent bowel movements or a change in the frequency, volume, weight, consistency, or ease of patches of stools. So meaning you could be stooling every day to every other day, but if you're only having little hard balls, hard stools, it is still constipation as well. And when we talk about the frequency of stools, that comes into our next slide, that how often do people poop? That's always a question. What's normal for stooling? What's abnormal? That varies between your transit time, your colonic transit time, which certainly increase over time. A baby transit time is about 8.5 hours, while an adult transit time may be anywhere from 24 to 48 hours. So for babies, if they're breastfed, they may be stooling anywhere from 0 to 7 times a day, average about 5 to 40 times a week, with an average of 3 bowel movements per day. A kid who is being formula fed is around 2 bowel movements per day. Very similarly, from birth to 12 months of age. 1 to 3 years, you can still be stooling up to, 1 to 3 bowel movements a day. And more than 3 years of age, while the average is once a day, you could be having a bowel movement every 3 to 14 days and be normal, as long as the stools are soft and not hard and not causing any discomfort as well. Other than constipation, I also want to touch on just a couple definitions of the first one being infant dyschezia. This is actually a baby that comes into the office. They don't have constipation. They're stooling daily in soft stools, but they have infant dyschezia. So right before a bowel movement, for about 10 minutes, they strain, they turn red, they cry, and then they have a stool and they feel much better afterwards. This is mainly for babies kind of learning how to poop. That's how I explain to parents. It's really hard to poop laying down, and you can't really coordinate the abdominal muscle contractions with the relaxation of the pelvic floor. So those kids, they don't need medication, they only need reassurance, and it's not necessarily constipation. Other definitions is intractable constipation, because I got a lot of referral for intractable constipation. Just keep an eye that this is actually constipation that's not responding to optimal treatment. Optimal treatment including medications, dietary behavior, and behavioral modifications as well for about 3 months. Which, sometimes we see kids, they'll try something for a week and say, it's not working. Let's just see someone else. And the fecal infection, it is important to recognize, because until we treat the fecal infection, constipation is not going to get better. So it is important. Sometimes they do need enema. Sometimes they will need a clean out as well prior to starting any kind of medication. We're going to focus today in functional constipation, which is 95% of the types of constipation. But what everyone kind of gets worried about is what else can cause constipation, especially Hirschsprung's disease, other cause. So I'm just mentioning here, other cause, Hirschsprung's disease is about 1% of all the constipation. We'll touch it in a couple of slides forward. Sometimes I'll do get labs on kids who are constipated, specifically for celiac and thyroid. That is an estimate on kids who have chronic untractable constipation, that about 3 to 8% may actually have celiac disease. So that's why it's part of our screening labs. Even though most of those kids are going to present with diarrhea, they can present with constipation as well, intractable constipation. And if you have any other like neurological issues, pelvic mass and spinal cord abnormalities, anatomical malformations, but those kids are going to have more of a history as well. When we talk about Hirschsprung's disease, again, 1% of the kids with constipation, those kids have absence of ganglion cells in the submucosa and the mesenteric plexus. Those ganglion cells, they, migrate from mouth to anus in utero, so they'll stop at one point. The majority of them are going to be only a rectal sigmoid, but it could involve the whole colon as well. Screening tests, you're going to have a history of this baby who has a delayed passage of meconium, the majority of times, abdominal distension, not tolerating feedings, vomiting. You could have a short segment Hirschsprung's and have a kid who is growing but having so much distension and a history of, constipation, that maybe have loose stools with a stool softener, but never have this large stool and had a delayed passage of meconium. They could have a short segment Hirschsprung with a late diagnosis. Screening tests would be the contrast enema, and the diagnosis, the rectal biopsy. A little bit in between Hirschsprung's and functional constipation on the kids that you see like in the office. So functional constipation normally does not start at birth, meaning those kids have a normal passage of meconium. They tend to have more fecal incontinence, while the kids with Hirschsprung's, they do not have that large rectum and they do not have that accumulation of hard stools in there, so they don't have fecal incontinence. If you do a rectal examination, you'll find in functional constipation really hard stools, dilated rectum, while on the Hirschsprung's kids, you're going to have a very tight rectum that if you take your finger off, stools can come on pressure. Like I've lost white coats doing, rectal exams on older kids who had Hirschsprung's. There wasn't completely diagnosis, and they have a history of they never pass any hard stools on with the Hirschsprung's kids. And the functional constipation, it starts with this very big poop and large that clogs the toilet, and that's something that's common. and they tend to have more fissures because of that. While, the Hirschsprung disease won't have any fissures or no large passage of stools. This is a real patient of a couple of years back. This was a call that I got from the ER with this kid with abdominal distension, hadn't had a bowel movement for a couple of days. They got an x-ray. This is what they saw, very dilated colon right here. And this was a late diagnosed Hirschsprung's disease. That was his contrast enema. He had a biopsy that confirmed. He actually had surgery and initially had an ostomy, then got reconnected. The history for this kid is he was 3 years old. He did have a delayed passage of meconium. He had constipation his whole life, which he was treated with Miralax. Mom was giving up to like 2 capsules a day, and he would actually have bowel movements on the Miralax. And anytime she stopped, he would actually back up again, but he never had a large stool. He never passed a big bowel movement, and he also wasn't growing well. So that's a couple of things. There's a kind of a giving up on this patient. For functional constipation, that's going to be the majority that you're going to see in clinic. Again, diagnosis, a history, and a physical examination. You normally do not need a rectal exam or an x-ray to diagnose constipation per se. The criteria for diagnosis of chronic constipation, functional constipation, varies on kids who are less than 4 and more than 4 years of age. For less than 4 years of age, for kids who are potty trained, you want to have no organic pathology and at least 1 month of symptoms. And kids who are more than 4 years of age, you wanted to have at least 2 months of symptoms, which included, 2 or fewer defecations per week, 1 episode of fecal incontinence per week after toilet training, stool retention, large fecal mass on the rectum, and a history of these large, big stools coming out. They may obstruct the toilet. So I saw a little girl who was 4 yesterday, and the mom mentioned, I had to buy a plunger because her stools are so big that I need to use the plunger to plunge. Right. And the GI history, what we wanted to know, again, meconium passage, characters of stools in the toilet, and also in the underwear. I got a lot of referrals for quote diarrhea, which they're actually having fecal incontinence and accidents throughout the day. If they're having any kind of stool withholding and the age that constipation started, and if they have any associated symptoms, including, abdominal pain, urinary symptoms, and what kind of treatment they've had before, because I do want to understand what the family is coming from and try to do an individualized treatment for every patient. The age of onset, again, the majority of functional constipation, it could start at any time, but it would start at 4 to 6 months of age with introduction of solids, 12 to 15 months of age, when you're changing from, formula to regular foods. 3 to 4 years of age, that's potty training time, and 5 to 6 years of age, that's when they go to school for kindergarten, and that's again withholding from 3 to 6 years of age. That's the main cause. While, on the earlier age is kind of a change on the diet. Testing, you don't always need to do tests right away when you meet a patient with functional constipation. There are times that when it's the first time that I'll meet them, I'll try to treat first. And then if they don't get better, that's when I will prefer the testing. You could choose to do a rectal examination if you feel like they have a fetal retention and a hard stool on the rectum. You can consider abdominal x-rays, which again, I'm looking for a rectal sigmoid stools. I'm not looking for stools on the right side. I feel like everyone that gets an x-ray in the ER comes back with the diagnosis of constipation and goes home with Miralax prescription or polyethylene glycol prescription. And lab work, if they're not responding, or if there is any questions for weight gain or concerns on the testing, and I'll reserve the other testing for kids who are not responding to the treatment or who are concerned with the history. Treatment, I like to divide the treatment in about 5 steps. The first step is family and child education. I may spend an hour with patients as in clinic to explain the pathophysiology of the constipation and why we're doing this treatment. You wanted to treat the fecal infection until that gets better. Constipation is not going to improve, and you may need to do a clean out. Then explain the maintenance of therapy. So normally, I would say most kids, if you treat it earlier, they could improve within 6 months, but there are kids that may need it anywhere from 6 months to 2 years of the treatment of with a stool softener and working on, behavior modifications as well. And we will decrease the dose slowly as well. And what kind of behavior and dietary modifications should we do? And that's individualized per patient as well. What works for one patient does not work for the next one. That's why it's important, that history. And also weaning of the treatment. Normally, I wean after 3 to 4 months of successful treating constipation, and I go very, very slowly. So if we're doing a medication, I'll decrease it by 1 teaspoon every 4 to 6 weeks as tolerated. So the majority of people tend to wean very fast within 1 to 2 weeks, and that's why we see failure a lot of times. Again, the education, we wanted to explain, the pathophysiology, fecal soiling, positive reinforcement, and repeat the education overall. So I do start by saying, understanding the problem, how does it start? Diet, while there is no evidence that doing extra fiber on the diet of a child actually treats constipation by itself, the regular American diet does not have a lot of fiber on it. That's why we tend to increase fiber and increase fruits, vegetable intakes. The majority of kids are having a diet that's already very low in fiber. So yes, increasing the fiber and changing the way they eat can be helpful, And I put a picture of a toilet there because a lot of kids, they are scared of using the toilet. Toilet can be disgusting. The stall doesn't close at school, or it's too noisy and you have the withholding. So until the withholding pattern stops, the constipation will never get better. So that's another thing that's really, really important. And I'll get kids that stop the withholding pattern and we're able to get off medications or anything way early. I do tend to do drawings for the family. This will be, the reflex and defecation reflex. So when stools reach the rectum, you're going to have a brain signal, and that brain signal is going to relax an internal sphincter and stimulate the contraction of the rectum and sigmoid colon. But you have to relax the external anal sphincter yourself. And that urge to have a bowel movement, this defecation reflex, lasts about 10 to 15 minutes. And after it's gone, you may not have the urge until the following day. These stools do stay in there, and with prolonged constipation, you have dilation of the rectum. So the next picture on the right, you just see, with the same size stool, you may not have an urge to have a bowel movement anymore. So it's going to take 1, 2, 3, 4 days to have that urge to have a bowel movement. So now those kids, they're not withholding anymore. They truly don't have the urge to have a bowel movement for about 3 to 4 days. So that's why it's important to, one, get rid of all this stool in there and making sure they're having enough soft stools to have the defecation reflex, on a regular basis. Again, overflow of stools and fecal incontinence. Knowing that you have this hard stool in there, whatever's coming from the top is soft. It's like mud going through rocks. And the internal sphincter is slightly open because of this rectal fecal mass that's in there. So that's when you have those little accidents that the kids don't smell, they don't feel it, it just happens. And every time parents look at it, at the underwear, it looks like there's a little bit of loose, very soft stools in there. And there are times that they will start on stool softeners like polyclinic glycol, and without getting rid of this fecal mass, and everything that's coming from the top now, it's super soft, and now it's more watery. So you're gonna have this history of, we tried this, but the accidents were worse, so we stopped. So this doesn't work. What else can we do? But the main problem wasn't taken care in the beginning, and that's why, it's important to recognize that. I'm not going to play this video, but it's right here if you want to watch. It's called The Pulling You. I do send a lot of my patients to watch it. It's made by Children's Hospital of Colorado and was made years ago, about 15 years ago, and it's got millions of views on YouTube. It's about a 5-minute long video explaining pretty much constipation, withholding patterns, and stool accidents on a kid's way, almost like cartoons. And this is actually was done by my son, who is now a teenager, when he was younger, and he did have withholding patterns in first grade. So that's how we had the whole drowning, and I kind of like had him do this for me in a way of understanding not to have an accident and not to have the withholding as well. How about behavior modifications? We do tell patients to sit in the toilet, but it's not sitting in the toilet every hour. The urge to have a bowel movement happens after you eat or after you wake up in the morning. So normally I say twice a day. After breakfast, if possible, and the schedule allows. Sometimes it's crazy before school, and at least, or after a snack after school or after dinner for about 5 to 10 minutes, not a punishment. And you do want to do that positive behavior. So their kids, they'll get chocolate chip or a little, sticker every time they go to the bathroom. And that immediate reward is important for the younger kids, other than just like a star reward. So getting that immediate reward is helpful. How about how should they sit? Do like step stools help? Actually, we're made to squat. So if you look in here, the position of, the rectus sigmoid, once you're just sitting and when you're squatting, does change and makes it easier to have a bowel movement. The picture on the bottom left also shows that, the toilet for adults, they're not made for kids. And it's really, really hard to push and to poop with your feet hanging. So it is important. I just tell parents just to get a regular step stool. Doesn't have to be anything fancy. Doesn't have to be anything specifically for it, just so their feet is flat in the floor and their knees a little bit elevated. And for the adults, just a step stool can also be helpful. So you're more in a squatting position. Or if you're using a toddler seat, it should be okay as well. I do ask people to keep a stool diary, but over time, I've gone from keeping a diary of like just a runaround in a paper to maybe just the calendar. I prefer calendars. I prefer monthly calendars so I can actually see how often they're pooping. There are apps from that. I have nothing with any of those apps. This is just an example of one of them that I've used because a lot of my teenagers and 10 and older, sometimes they have phones and they may have their phones when they are pooping as well. Then they can bring it over and we can go over the diary of the stools and see how often they're actually having bowel movements. And I will ask them to adjust the stools, the medication based on the stool pattern. So it is important to have that tracked. And it's super hard, as a parent, like after they potty train, you just don't go and see their poop every day. So having them keeping that diary is helpful. We talked about, before starting a maintenance therapy, we wanted to do a clean out. The Society of Pediatric GI in the US does to recommend an oral clean out as first line therapy. In other countries, enemas are using more often. I do use enemas as well if a kid's having a lot of accidents, but it is harder for parents to do it at home. So the first line that we tend to start would be with oral cleanouts, which you can use, the one that I use the most is polyethylene glycol, which you can go for younger kids, 1.5 grams per kilo per day over the course of 3 to 6 days, meaning a higher dose. And the clean out just in a day, what we do for colonoscopy is about 4 milligrams per kilogram per day of polyethylene glycol mixed in like in a sports electrolyte drink with a max of 14 capsules in a day, plus minus an stimulant laxative like Senna. And you can also do the commercially available, electrolyte solutions and polyethylene glycol. If they do have the hard stools and a lot of soiling, I do believe they benefit from a rectal disinfection and doing an enema, and I do that before the oral clean out, just to get the hard stool before. I tend to use saline enemas primarily. Do not recommend soap suds or tap water enema. If they do fail everything, then we can consider inpatient cleanouts, but I rarely admit kids just to have a cleanout, and we see kids with constipation every day, multiple times a day. And about, 2 to 5 times a year, I may take a kid to the OR to do a rectal disinfection. If they completely fail, I'll the above, which is exactly what it sounds, bring them to the OR and we take it away some of their hands and we put a colonoscope as well, just and try to do a little enemas in there. Pharmacologic treatment for maintenance. Those are the kind of the options. The one that we use the most is polyethylene glycol and lactulose. Dosing vary from, polyethylene glycol, even though it's not FDA approved for kids, the recommended dosing is to start at 0.4 grams per kilogram and normally 0.2 to 0.8. There are studies on kids, and there was this systematic review a couple of years back, and they realized that people are using dosing anywhere from 0.2 to 1.1 gram per kilogram per day of polyethylene glycol, and that was well tolerated. For lactulose is 1 to 2 grams per kilogram per day. Based on a concentration that's more common one, is 1 to 3 mLs per kilogram per day. So I normally think about, I start at 1 ml per kilogram per dose once, like 2 to 3 times per day with a max of 60 mLs. And how do you measure the polyethylene glycol dose? We're talking about grams here, and no one has a scale in the house, and this is what the parents are going to see. You see a little capful, and everyone talks about capfuls, and I'm talking about grams. How are you going to measure this? What is the idea behind when I say 1 teaspoon, 2 teaspoons, 3 teaspoons? So I actually measure this at my house. This is not the manufacturing or anything. So if you fill up a full capful of polyethylene glycol, 17 grams, and if I measure that with teaspoons, my home baking teaspoons, 1 teaspoon is about, 1 capful is about 5 teaspoons. So 1 teaspoon is about 3 to 4 grams, 3.4 grams. I do tell parents to use like medication cups, like that's kind of a liquid medication cups, because normally they tend to have teaspoons measurements because you can't put the teaspoon inside of the container. And that's just an example of, 2 teaspoons measurement on one of those medicine measurement cups, and that's a 7 grams. So it's about 3.4 grams, 3.5. So that was correct in there. And that's a way of keeping the same dose on a daily basis and be more consistent. Because if you just look at the lines there, the lines go around and they're not straight. You may get questions about safety of medication because it's not FDA approved for kids, but again, has been effective in multiple studies. We have been using polyethylene glycol for over 25 years. It's been on the market since 1999. It is water soluble. It is non-toxic. The majority is not absorbed by the GI tract. That was a big questions and concerns specifically about 5 to 10 years ago, that came on primarily the autistic community. And kids who were on polyethylene glycol for long periods of time. So that is a whole Facebook group that has over 100,000 people. They're completely against polyethylene glycol, and I've never joined because you have to agree with their, rules, which are very strict. And at this time, I normally say if I have a patient, a parent who truly does not use, polyethylene glycol and wanted to use something else, wanted to do a more natural way, there are options in terms of fibers or other supplements. and I'll work with the parents, not against the parents. So I'm not going to be saying, keep doing this, and I know they're not going to do it, but I do try to educate them and show, there was a study at CHOP that did not, was not finished, but preliminary results did not show any evidence of, any reactions of polyethylene glycol, and is proven to be safe. That is a position paper from NASPGHAN, which is the Society of Pediatric GI, saying that is at this time there is no evidence to support any serious side effects of polyethylene glycol. I do feel like anytime that I'm treating constipation, I'm treating not only I'm telling parents to give you this medication, but I'm also telling the parents to change the diet of their kids, to have them sit in the toilet twice a day. So that for me changed behavior more, and it can be frustrating for the kids than the medication itself. Normally when I talk to parents, the behavioral issues were there before, and they don't completely go away if you're stopping the medication. But they do get better once we treat the constipation, because it can be very uncomfortable for them. That brings us to non-pharmacologic treatment. There are parents that may say, hey, I don't want to do medication. What options, what else can I do here to, treat this? Fiber is a big one. So should we be giving fiber supplements to everyone? Not necessarily, but it is recommended that kids have the appropriate fiber intake. So the recommendation is actually a normal fiber diet, but as we mentioned before, the typical American diet does not have a normal fiber diet. It tends to be lower in fiber. So that is normally, I do recommend kind of increasing the intake, unless those patients that already have this amazing diet, I'll tell them, there is not much work on the diet itself here. We may just need to add a medication or add some behavior change as well. What is the recommended intake of fiber on kids? As you can see here, it varies from 19 to 38 grams based on age. For very young kids, even 19 to 25 grams of fiber per day. And for teenagers, anywhere from 31 to 38 grams for boys and 26 grams for girls. Talking about fiber, how much fiber is in every food? You can see it's primarily, fruits and veggies tend to have the highest fiber. Kids in Hawaii tend to eat a lot of rice, so sometimes I do have them to switch from white rice to brown rice. 1 cup of brown rice has 3.5 grams of fiber against 0.6 grams per white rice. Beans are a big one for fiber intake. So if they add beans to their diet, it can be very helpful, as well as different, fresh fruits and like apples, blueberries, strawberries, those all have higher. And the ones that we think about, pears and plums and prunes as well. And how about fiber supplements? Those are natural ways of getting fiber. Psyllium husks, you can buy psyllium husks because you can mix it in water, but it becomes really hard for kids to eat it, to drink it, because it just becomes a gel. There are studies on adults that psyllium helps. Psyllium is the main component of Metamucil as well. But there's no great studies on kids. It's for some parents, I'll say, if you're making something, just add a little bit of psyllium to pancake batters or something. Those are all ways of adding fiber to their diet. Cellulose, there is more studies on adults, none in kids. Glucomannan, it's actually a derivative of konjac, which is a seaweed. There are some studies that have some improvement from placebo, but those are questionable. Flax seeds, there are studies on adults, not necessarily on pediatrics. Great studies. Cocoa husks, there are studies on pediatrics on that. And the fiber mixtures as well, fiber gummies. There are studies proven that, they do help. But with the fiber, the idea is they just pull water just like the osmotic laxatives, and you have to do it every day. So anything that you choose to do, you have to do it on a daily basis and then kind of decrease it slowly. Prunes actually work. They work the same as the osmotic laxative that's used the most. They have a really high osmolarity. They have really high sorbitol, so they work primarily as an osmotic laxative as well. Eating prunes works better than drinking prune juice. How about fluid intake? We keep telling people to drink more water, drink more fluids. Again, a normal fluid intake is actually recommended in kids with constipation. But with that being said, what is a normal fluid intake? This is the recommendation. It's actually pretty high if you look at it. It varies from anywhere from, 40, 50 ounces to 80 ounces a day of water. And most kids are not drinking that much. So that's why a lot of times I'll still have parents have kids increase the fluid intake. But if they're already drinking, there are studies proving that just by increasing by 50% of their eating, of their what they're drinking, if they're already drinking enough, and what's recommended does not treat constipation by itself. And again, there was that study, if kids are already taking enough fluids, increasing by 50% was not effective on increasing of treating constipation or changing the school frequency or consistency. How about dietary change? The one that we get the most questions about is dairy-free diet. There have been studies looking into dairy-free diet on kids. The first one was an open label study on, it was dairy-free diet versus milk versus rice milk. The second one was crossover study between milk and soy milk. And they actually showed some improvement on and possibly being taking milk away from kids' diet, helping with constipation. The third study was a randomized clinical trial that was actually more interesting because they used patients who were already on treatment, but they're actually not responding to the treatment with stool softeners and behavior modifications. So those kids are 4 to 14 years of age. They had about 70 kids or so, 75. And they actually, the kids that went on a cow's milk diet had a better response of about 71% versus 11% in the other group. So that's actually significant. And that was one of the studies that showed that you may indicate, a 2 to 4 week trial of avoidance of cow's milk diet could be indicated if the kids do have intractable constipation that's not responding to the treatment. But it's not always the first line therapy. Just if they're not responding, you could consider, doing a trial of a dairy-free diet. You do not need to do any allergy testing because this is not an allergy. Constipation is not an allergy presentation, and unless they are having other symptoms that you're concerned about an allergy itself. How about botanicals and supplements out there? There are tons of supplements. I get a lot of supplements all the time sent to me by parents. Even though they're natural, it doesn't mean that they're completely not harmful, or they can't be just like medications. The majority of them are actually senna. Even the laxative teas that everyone is taking, and a lot of my teenagers take, it's senna, and it's actually a higher dose of senna or some degree of fiber as well. Other complementary therapies, they haven't been shown to improve by itself. They could be used as a adjunct therapy, but not by itself as well. What is the prognosis? What's going to happen to kids with functional constipation? The majority of them are going to get better. But we do know that if you delay on the medical treatment from the symptoms of onset, then you're going to have longer duration of treatment. So if you identify early, about 80% of kids are going to get better and recover without any use of medications within 6 months. Which is different if you do not identify early if they're having symptoms for a while. Only about 30% will get better within 6 months. We do know that the majority of kids, when you treat it, will get better within a year. And if they stop the medications, they could even relapse within 5 years. So not unusually, I'll discharge someone from my clinic 2 years later, they're back. They're just relapsing with some constipation as well. Reassuring for the majority of parents is even the kids who are suffering, the majority of them will get better when they're older as well. And 80% recover after age 10 years of constipation. And I do feel like it's kind of learning in terms more of working on the behavior part, not withholding. It's really hard to tell a 3 to 5 year old not to withhold their stools, but it's easier for me to tell a teenager not to withhold their stools and to change their diet as well. And that's actually when the little kids tend to need more medication than the older kids sometimes, because little kids, to control a diet of a 3-year-old and to give that amount of fiber and supplements every single day, it may be easier to make something and give them in the water, and they take that and you teach them that pooping doesn't hurt. That's really the goal. We want daily soft stools, the minimum dose possible to give them daily soft stools. That is the idea of treatment. And you don't want them to have diarrhea. You don't want them to have hard stools as well. I put here the guidelines from NASPGHAN, but I'm not going to go through everything. It's very long. I did try to simplify this a little bit. And my idea is, if I diagnose a patient with functional constipation, and I believe that is, primary functional constipation, I look into, are they soiling or having, accidents? Are they having fecal incontinence? If they do, then they will likely benefit from a disimpaction of like enemas or something from the bottom, plus minus, or a clean out, like definitely a clean out, and plus minus a disinfection, I would say. So if the kid has never had any treatment, I may try just to do orally first with a close follow-up. And if they don't improve, then we'll do something through the rectum as well. After the clean out, then you want to, do the education, which you do in the first visit, and definitely change their diet, make sure they're having enough, fluids and fiber as well. Laxatives or stimulant laxatives or osmotic laxatives, whichever you wanted to choose, and behavior modifications, which are, not withholding the stools, that's the main thing, and schedule toileting time, and not being scared of using the bathrooms as well, and then slowly weaning the medication. So I tend to keep kids on the medication for about 3 to 4 months if they're doing well, and then wean the medication by about a teaspoon every 4 to 6 weeks. So very, very slowly. I do see kids using the medication, use this medicine and chill, these stools are soft, and then just decrease it within 1 to 2 weeks. They do improve, but they do better for about 1 to 2 weeks, and they go right back into constipation as well. If you have a history of physical examination suggesting like an organic cause, a delayed passage of meconium or something else, or an interactive constipation, then you would have to consider more testing and treat accordingly. What are the main kind of my personal experience and what do I see being the main pitfalls and things that we can all improve as providers is not removing the fecal infection. So you should not only diagnose functional constipation, but see, is this kid impacted? And I wanted to remove this fecal infection before treating with a maintenance dose and medicine therapy. Or we'll do a clean out, and after the clean out, they never start anything. They just do a full clean out. They get, an enema in the ER, and sometimes they're told to do the medication every day, but not given necessarily, or the parents may not understand they're supposed to continue to give it. Giving too low of a dose. So I'll have kids that are taking older kids taking a teaspoon of, the powder that's more commonly used. So it's the polyphenol glycol, just a teaspoon. So 3 grams for a older kid, it's too low. Or a little baby who's actually like a 1-year-old that's taking a quarter of a teaspoon. So we talked about 1 capful is about 5 teaspoons. So a quarter of that teaspoon, it's a very, very low dose. It's not even 1 gram of the medication. No follow-up visits, meaning, we assumed the parents understood what I was telling them, and we say, I'll come back for the follow-up next year for the well child. they may need to be seen within like 4 to 6 weeks just to have the reinforcement they're doing okay and see how they're doing and make sure that we don't need to adjust. And then I will see them every 2 to 3 months to do adjustments on the medication and see how they're doing within the adjustments as well. We don't want to stop the medication too soon. And again, providing education and guidance. I do understand that we're very lucky that my visits are for new patients an hour and for follow-up half an hour. So we end up having enough time to spend with the parents. And I may spend an hour just talking about the pathophysiology and how do we treat constipation. And all we're doing is just kind of reassurance and education primarily. About by the parents, sometimes parents are not doing that scheduled tolerant time, which is very, very important for the kids to recognize the time to have a bowel movement, not giving the desired intervention or sometimes stopping the medication, saying, you're good, let me see how you do without this medicine. And they may stop too soon. They'll do okay for 1 to 2 weeks and they relapse, and not restarting after a relapse as well. I have one clinical case here that was a patient that came to me. She was actually from Guam, and she with a history of constipation since a very, very young age. She had an oral passage of meconium. She was a teenager. She started having constipation after 1 year. At that point, typical history of constipation, one bowel movement every 1 to 3 days, very large and hard. Then at a later age, started having stool withholding and fecal incontinence. She was starting polyethylene glycol, but had way more accidents. So the parents stopped the medication. She was working on a diet. She was actually drinking like 80 ounces of water per day, 80 to 100, and had a good diet, but did not see any improvement on her constipation. She came here to Hawaii and went straight to the ER, and she was seen in the ER. She had a week without a bowel movement, and they did an x-ray. So this was her x-ray, and you can see here the rectum. You have this 11 centimeter mass in there. That's a really, really hard stool that's been in there for a while. So they did a substance enema at the ER. Normally, I won't do substance enema, but they did one. It's fine. Not too much came out, a little bit came out, and she was prescribed a polyethylene glycol oral clean out, and then 1 capsule twice a day, and referred to us. So I actually saw her in clinic, but a couple of days later, after this ER visit, and she told me that she had the whole clean out. She had no hard stools. She had a bunch of liquid stools. The soiling was better, and she was actually feeling much better. So if this was a telephone appointment, that would be it. And like, oh, you're great, keep doing the, polyethylene glycol. But when I examined her, I still felt very hard stools on her left lower abdomen. I did do a rectal examination because of the x-ray that I saw in the ER. She had a very dilated rectum, and she still had very large hard stools palpated in there. I did prescribe her another clean out to do it at home with 2 enemas 12 hours apart and a high dose polyethylene glycol. And she was prescribed polyethylene glycol and Senna for maintenance of therapy. I saw her in 3 days because she was going to go home within like a couple weeks. So I was seeing her very often as well. She had a lot of stools after the clean out. She was feeling better. And she told me, I have daily soft stools. But she was in clinic. So when I did a physical examination again, she still had really hard stools on the rectum, palpated on her abdomen, sorry. And we repeated an x-ray on that day. I did not do a rectal examination. And you can see here, you can still see stools, and you can still see this really hard ball on her rectum as well. Despite, she's had 3 clean outs. She wanted to try again. Next steps, what do we do next time? Do we admit her to the hospital? Do we do a, inpatient disinfection or disinfection in the OR? She actually wanted to try at home again. So we did a mineral oil enema, and we did like the commercially available 4-liter, polyethylene glycol and electrolyte solution. And I saw her back in about 2 days to see how she was doing. And she said, I know I had the enema and I had no stools whatsoever, no hard stools, which I would expect her to have a hard bowel movement with so much poop that she had on her rectum. And she had a lot of bowel movements, loose stools with the clean out, but I still could palpate, that hard ball on her abdomen. I did an x-ray, and while her whole colon was clean, she still had this really hard stool on her rectum. So we could have ended up here because she was feeling better, but we did bring her to the OR to do a manual disinfection of this patient. And after the manual disinfection, she was started on polyethylene glycol and Senna, which she used the Senna for about 3 months. And the polyethylene glycol, she was on it for about a year, and she was able to wean out the medications. I have seen her about 3 times. Every time she comes to Hawaii, she comes to see me, and she's actually doing well and currently off any medications and has not relapsed her constipation. But again, it's a teenager that could understand. Do we have time for those MLC questions, or?
Yeah, we still have several minutes.
Okay.
Oh yeah, go ahead. And then there's lots of interesting questions in the chat too, as soon as we finish the MLC question.
Okay. So this is just a 2-month-old, super irritable prior to bowel movement, just crying, but just having daily soft bowel movements, no blood in the stools, growing well, no abdominal distension as well.
I can go ahead and run the poll.
Okay.
So you don't have to read through.
Oh, sorry.
No, it's okay.
I was like, what is that that showed up? What's the poll? And what do you want to do with this patient? What's the approximate? I can't. Yeah, I don't think I can move the poll. Yeah.
Yeah, we can give everyone a few minutes, maybe a couple minutes to complete, and then we can go over them.
Okay. So do you go over all the questions first? Do you complete some?
If there's some with like a wide variety of answers that need to be reviewed, most of the time, a couple of them we'll go over. But we have a lot of time, so we could go over each one. But there's also a lot of nice questions in the chat, so.
Okay, I don't see a lot of answers here. I don't know. Do you want to?
I think we'll give them a little bit more time. The questions are quite kind of lengthy.
Okay, yeah.
And then number 2 for the third choice, how old is the male in this answer? 2-year-old, okay.
Yeah, 2-year-old.
Okay, why don't we can go through them. Well,
Okay, so it's okay.
I'll leave it
So
open.
the first one was, a 2-year-old with, this kid has infant dysphagia. So the answer is correct. It's a parental reassurance. You don't need to start this kid on any medications or anything. This is a baby who just has, crying with bowel movements, but normal stools otherwise. The second question, would be the kid that kind of meet criteria for functional constipation, use the criteria, and the correct answer is B. So it is correct. Most everyone answered correct, which is a 19-month-old with a 6-month history of very painful large bowel movement every 3 to 5 days and intermittent fecal incontinence for the past month overall. The third question, I can't, because the poll shows up right in front, so I can't read the question. Can I take this away or no?
Can you move it? No.
I can't move. Yeah, it shows up right in the middle here. So let me see.
Okay, I'll just go ahead and end it, and then maybe you can see.
Okay. I can't move that because it shows up. Okay.
Is it still, do you folks still see it?
I don't.
Okay, I see it. Okay, there we go. Now I can close. Okay. So the third question is, a 3-year-old has a constipation for about 2 years with typical, functional constipation, has very large hard stools. Occasionally, he may have bright red blood on it, which again, constipation is the most common cause of that. Very picky eater. They've tried polyclinic glycol and hasn't really got better. But on the history, he had a normal passage of meconium, normal rectal examination, except for very dilated rectum and very hard stools palpated. So you do, parent education about functional constipation, the treatment, and what is the best management of this kid. Again, this is a 3-year-old. They don't always, so you want to do a clean out. I tend to choose to clean out over the course of a couple of days for this kids. So that's where I'll do the 1.5 grams per kilo per day, followed by around, 0.5 gram per kilogram per day of daily polyclinic glycol and stool softener, and with a close follow-up within a couple weeks. You do not need an abdominal x-ray. You already have a diagnosis in this kid by the clinical. He doesn't always need referral to pediatric GI if the parents really want it, but this is kind of the idea here is that they don't always need to see us. He can be treated first and you can do a clean out before as well as seeing us. And the first one was kind of just increase water and fiber, 2 times recommended for age. And as we talked about, there's no recommendations of going over what's recommended for the age of patients. The question number 4 here was what's false regarding constipation, based on the guidelines. And that is actually that every patient should have an abdominal x-ray and digital rectal examination. For the opposite, I actually don't do x-rays very often on my patients. They come in with x-rays that are done before, but I don't do x-rays to evaluate for constipation. I do look for fecal infection, and that's mainly when I'm doing a rectal examination as well. If I think the kid may have Hirschsprungs and may have some rectal abnormalities, or they have fecal infection. The other ones are all correct. You should do a normal fiber and water intake, and the diagnosis is based primarily on the history and physical examination, and routine x-ray is not recommended. And I'll end right here with, everyone does poop, and I'll stop sharing this screen if you have any questions, concerns, or I can leave this screen and let me know if what comes to the chat. I don't know if I can see the chat.
I can tell you some of the questions. So the first one was about routine, and that was when you were talking about constipation. And I know that I was taught in residency to always have them to sit on the toilet after every meal, as similar to what you mentioned. But I've also noticed that when I see kids in the hospital with constipation, that a lot of times that aspect hasn't been covered. So I appreciate, Renata, that you emphasized that. The other ones are questions about pectin, turmeric, and coffee enema. So maybe since it's a couple minutes after 1:30, you can take your pick on which one to answer, or click through all 3.
So I do not recommend coffee enemas or any kind of other enemas that are out there. There was actually also, there are tons of case reports on different TikToks or even social media stuff and people doing different enemas. I just do saline enemas or mineral oil enemas for majority of my patients and our fleets.
Pectin and turmeric were the other two questions.
Turmeric for both bowel health. I do use turmeric for kids with inflammatory bowel disease. There is evidence on ulcerative colitis as an adjunct therapy. Patients on mesalamines and turmeric, like 3,000 milligrams per day, they actually respond better to the treatment than kids who are on only mesalamines. But by itself, it's actually not shown to treat inflammatory bowel disease. There are a lot of studies on, turmeric and anti-inflammatory properties. Again, it won't treat the constipation, but the person also recognize that, Renata, but it's not going to hurt them. If they wanted to do turmeric supplements, I'm okay with you doing some turmeric supplements. I don't routinely recommend to all my patients, mainly because it has to be on a tablet or it has taste, but I do recommend to my inflammatory bowel disease patients for a select group with mild ulcerative colitis that are on mesalamine treatment. Pectin are also, they are prebiotics. So it's primarily like, those, it's within the prebiotic, like fibers, it's healthy. I don't always add pectin to it. It does thicken up the bowel, and even I use pectin for a lot of kids with short gut to actually slow down their bowels a little bit and to thicken up their stools. It is more of a stool thickener that I use more. I don't use it originally on constipation. So, and yeah.
Okay, great. Super interesting. I really, as always, enjoyed learning from you, and I'm sure all of our participants did too. So thank you so much. We